Hello and welcome. Tonight we're talking about the brain disease Parkinson's. It's a disease that is very, very common in our country. 1.4 million people have the diagnosis of Parkinson's disease. In our Twin Cities, 12 to 15,000 people have it. If we think in terms of statistics, about 1 out of 100 people over age 60 get Parkinson's disease. We have learned quite a lot about it. At least we've become more familiar with it because of the work of Michael J. Fox in making it more known as a disease. But tonight we're with one of the national experts, and so we have a chance to really learn from you and with you. My guest is Dr. Jawad Bajwa, who is at the Bethesda Hospital, and you're the medical director there of the Capistran Center for Parkinson's disease and movement disorders. You are also the medical director of Deep Brain Stimulation program for movement disorders at United Hospital, which is also, of course, in St. Paul. You are a busy man. You're the medical director of the American Parkinson's Disease Association in Minnesota. And you're affiliated also with the Neurological Associates of St. Paul. And in Minnesota now only 9 months, coming from the Cleveland Clinic, right?
Yes.
So welcome officially.
Oh, thank you so much.
One of your official welcomes. Dr. Bajwa graduated from the King Edward Medical University in Pakistan. He did his internship at Mount Sinai School of Medicine in New York. His residency was at Georgetown University, and his movement disorders fellowship training was at the Cleveland Clinic. So we're very lucky to have you here. I guess my first question is, if you were sitting on an airplane and the person next to you wasn't familiar with Parkinson's disease, how would you explain it, Dr. Bajwa?
Thank you for the invitation and also for having me here. It's a very, for physicians to come up with lay terms is the most difficult part. But how I would describe it, Parkinson's disease is a disorder which generally affects your movements. Slowness, stiffness, tightness, rigidity, which we call in medical terminology, gait, balance changes, people frequently falling, and tremors on occasion. That would be a kind of an overview how Parkinson's disease would appear to a layman person. And I go around, since I've been in Minnesota, to many communities, support groups, physicians, and I've been stating this fact that it's one of those diseases, probably in its own way is unique, that absolutely defines you as a person. Because you could be walking in a mall and people will take a note of your walk, your tremors. I mean, you can have, unfortunately, you can have any other disease.
Heart disease or cancer, and people wouldn't know it.
People wouldn't know that you're on 20 other medications. But whether you are on a medication or not for Parkinson's disease, it will be recognized. And that really defines almost all of these patients socially. So when I see these patients, it's one aspect to treat them for their medical comorbidities and symptoms and signs, but there's so much from a social perspective that goes in. Because after all, we as Homo sapiens, one of the most fascinating thing about us is our refined movements, which no other species has on the face of the earth. Our ability to be dexterous and able to hold a pen, able to write or maneuver a screwdriver, no other species can have that fine movement. And when all that gets affected, it really defines you as a species and as a person.
It's a very tough disease to have, and yet I heard you speak recently, and there is a lot of hope also too for Parkinson's patients, isn't there?
Oh, absolutely. I mean, I almost say to my patients who come to see me, there is no reason for you to live less than suboptimal life in terms of quality with Parkinson's disease anymore. From our armamentarium of medications, which are almost getting close to a dozen pills, which are available on the market. It's probably one of the diseases in neurosciences where we have so much options available from medications all the way to surgical options. So really, nowadays, even though we don't have a cure, and everybody comes and asks me, when are you going to find that cure? And I say, well, hope is on the way. Because if you look at 3 decades, we have come from a single pill, levodopa, which was back in mid-60s, all the way to now having multiple pills which augment the function of cinnamon or levodopa, carbidopa, one way or the other. So a lot of hope.
When we talk about the symptoms, can you just briefly tell us what's going on in the brain? What's not happening that should be happening?
There are certain parts of the brain. Brain is a complex organ, one that you cannot even transplant. Heart you can, kidneys you can, but brain you cannot. It does so much for us, and it takes a lot of beat from us too. And parts of the brain which regulate movements. They are basal ganglia. It's a medical terminology I'm using, and there are a group of nuclei within that basal ganglia that regulate movements. So the disease, Parkinson's disease, is focused on those nuclei. So basically, substantia nigra pars compacta is a nucleus within that circuit where dopamine is made. And for some reason which we don't understand, the dopamine becomes deficit.
And so not enough of it.
And these patients don't have enough of dopamine. By the time they're about roughly 60 to 70% less, that's when we see the clinical symptoms of Parkinson's disease.
Do you think, Dr. Bajwa, that people have an onset of Parkinson's for many years before they actually show the symptoms you've described?
Oh, absolutely. I think the truth of the matter is that you probably have to lose about 60 to 70% of your dopaminergic neurons to physically or phenotypically manifest the disease.
Say the percentage again.
60 to 70%.
60 to 70 before you even show symptoms.
Absolutely. It could be even sooner, but it means by a general idea that you have to have a substantial loss of those nuclei. And so the disease has already begun. So when most of the patients we diagnose, when they say, well, my tremor started about 1.5 years ago, well, that's when the physical manifestation of the disease started. But truly, by all measures, it was probably 5 or even 10 years or even longer that your disease process actually started.
Does that mean then that it's more difficult to treat because it's been developing in the body all these years?
You raise a very good point, because now our struggle is in the movement disorder scientific and clinical community is how to preclinically diagnose these patients. So we are able
to catch them
absolutely.
Way back. Really.
If I could have somebody come into my clinic and say, Doc, can you predict if I'm going to have Parkinson's disease or not given these XYZ risk factors? Then wouldn't that be one step ahead of the game? And second, that will make it far more rational to use therapies which we don't have available, like neuroprotective. Well, here's something that you likely have about 70% chance of having Parkinson's disease, and this is what we're going to be giving you in order to take care of it. So I think you're absolutely right. Our struggle right now is, in much of the work that is being done from imaging to medications and pathophysiology, is how to determine preclinically patients with Parkinson's disease. That's going to be a big breakthrough whenever that happens.
Now, there are atypical Parkinson's diseases too. Less common, I'm guessing.
Absolutely.
But in terms of diagnosing, is it difficult to make a differentiation between what we might call pure Parkinson's versus atypical?
You're absolutely right. I think clinically it's always a challenge, even for specialists, subspecialists like myself. And because in the initial stages of the diseases, things can very much overlap. The tremor may not be there, so you cannot say for certainty this is not Parkinson's. Rigidity may be similar in both sides, arms and legs. Gait problems may be similar, but there are always some red flags that may be there in the beginning that may not. So yes, in the very early cases, sometimes it's always not certain, but there are soft signs that may make you lean towards a potential diagnosis.
And this then makes me say to myself, if I had a family member with any symptoms at all, best to get to neurologist, or even better yet, a movement disorders specialist, right, to get this figured out.
Oh, absolutely. It's one of the most, we live in an era of medicine where everything is based on, to a great degree, on clinical skills, but now augmenting is a lot of our tools, imaging, lab. Fortunately or unfortunately, with Parkinson's and movement disorders, we don't have that liberty yet, and the diagnosis is universally clinical. So absolutely, it does make a difference to be seen by the right person, have the right diagnosis, because really, your care, how it is determined in the beginning, will affect how you are 5 to 10 years down the road. So you really don't want to be in 5 years misdiagnosed or not diagnosed. You really want to know very early on and then take the right steps to make sure that 10 years from now, you still have a very decent quality of life.
And that is possible, to have a decent quality of life.
Yes.
See, I
with all due challenges, but yes, it's possible.
With challenges,
yes.
Of course. Is it hereditary? You know, it's very common, 1 out of 100 get it. Does this mean if you have someone in your family that has it, you're more likely to get it too?
Right. 10 to 20% of cases, generally speaking, are genetic. Less than
10 to
20%.
Okay.
People who are age 40 or less are more likely to have a genetic predisposition, people who are elderly, like age 60 and above. That is why we call it idiopathic Parkinson's disease. Idiopathic, we don't know why. So people who are elderly, even though they may have more, still genetic predisposition, although we think that environmental and other factors may perhaps make a bigger role. People who are younger, like Michael J. Fox, or many other like of similar age, we likely think they probably had a more genetic predisposition. And we have come to identify certain mutations. PARC is one family of gene mutations, PINK is another. But clearly, it hasn't changed. That information is being pulled in, and geneticists are looking into it to carefully determine patterns, inheritances, who gets affected. For now, that has not definitively changed our clinical practices, how we manage these patients. But yes, certainly it could be genetic as well.
And as I did my learning about this, 1 out of 10 people get this disease who are the younger people, under 45, right? 1 out of 10.
Absolutely, and that makes it roughly 10 to 20% of people who likely would be 40 or younger will get idiopathic Parkinson's disease. And it's, I mean, it's probably not surprising that most of us who do this 24/7, we have a distribution of patients which are as young as their mid-teen, 20s, all the way going up to their mid-80s and 90s. So it's a disease, even though it's heavily manifested in elderly, but it spans the whole life spectrum, and anybody can get it.
It just makes me sad to think of young people getting it. Does it progress in a different way if you are a young patient compared to a person over 65 or 60?
For the purposes of describing it, not much, but yes, in certain ways they are. People who are young onset Parkinson's tend to have more of a rapid course than people who are elderly. Their side effect profiles for medications tend to be a bit different than people who are elderly. They still have the same distribution or the variety of phenotypes of Parkinson's they can get. So for by and large, there are subtle differences, but mostly both diseases progresses typically similar. I think the contrast issue is the social expectations of both scenarios. So even though the diseases may look alike, 65 versus somebody who's 35, but the social expectations is probably more profoundly affecting the one who's 35 versus who's 65 or 75, where their debate is completely different. So that's where we get into it, more of the delicacies of these two age groups in terms of the Parkinson's.
I just want to detour 1 quick minute to ask you about essential tremor, because not everyone with Parkinson's has a tremor, but a lot of people do. But essential tremor, just explain what that is briefly, and then
You raise up a very good question, because it's one of the most misdiagnosed. People with Parkinson's can be diagnosed having essential, and people with essential tremor can be misdiagnosed having Parkinson's disease. The tremor in essential, it's generally considered a genetic disease. It's called benign essential tremor. Benign meaning it's not as malignant or perhaps not as problematic as Parkinson's tremors are. Although our concept and thought is changing about essential tremor also. But more so, the tremor is not at rest. It's mostly with action and posture. The frequency and amplitude is certainly different than a typical resting Parkinsonian tremor. And then if that doesn't differentiate it clearly, then you have other things. People with Parkinson's will have slowness, will have rigidity, may have gait troubles.
Those things don't go along with essential tremor.
Typically they're not. So sometimes if these other simple things cannot distinguish, then you need to kind of move on to other comorbidities and other symptoms and signs to kind of lean you one way or the other. The other thing with essential tremor is it spans again the whole age. People mostly have history of 20, 30, 40 years with no significant impairment of their physical abilities other than the tremor part. Mm-hmm. With Parkinson's, the history is very different. Mm-hmm. With 5 and 10 years, if they're not diagnosed, it'll be a cumbersome process to get through it.
If you have a tremor and you find out it's essential tremor, you are one of the lucky ones comparatively.
True, compared to having a Parkinsonian tremor.
I want to shift gears and talk about some of the treatment. And because you are a person who does deep brain stimulation, we're, I think, all curious about how that is working. And you brought along some show and tell things here.
Right.
But is having surgery something that I know not all people with Parkinson's are good candidates, but is it something that a good number can benefit from?
Right. The American Academy of Neurology data, which is certainly what we see clinically also, is that only 10 to 20% of people are eligible for DBS.
10 to 20, okay.
And with idiopathic Parkinson's disease. So that's why it's a very selective treatment for selective patients. And the reason I always tell my patient that everybody is a candidate, but if you have these, which are a list of things which are contraindicated, then we may not be able to proceed. For instance, cognitive decline or cognitive issues or dementia underlying, mood disturbances, behavioral issues. These are some of those things that really, which are very common in patients with Parkinson's disease, and that absolutely makes us difficult to conceive that they'd be a good candidate for surgery, because the likelihood is that they're going to get worsened after it. So my role as a movement disorder neurologist is to provide the preoperative counseling, the right diagnosis, and explain to them what this therapy does. Mm-hmm. I also work with surgeons where I'm in the OR doing the physiology part to exactly localize where that lead needs to go. And the long road ahead of after the surgery, which people never undertake to consideration, is the frequent visits to the neurologist, multiple programming sessions. Because if you start one medication, you would wonder, you probably need quite a bit of juggling with that one pill to make it right. Mm-hmm. Well, that's the same amount of juggling you need with something like deep brain stimulation. And here's what I wanted to show, what I brought along. This is a typical DBS programmer that we use for the device we implant. And there are about 30 to 32,000 different ways that you can program that thing, from multiple frequencies, pulse widths, contexts that you want to use, settings. And that just tells you that the complexity of it, the therapy is great, but the post-operative care in the right hand is also required.
So I just want to double check. Deep brain stimulation is only for people who are not having cognitive decline.
That's probably a very reasonable statement, but there are always the people on both sides of the street, exceptions. Mm-hmm. But if you already have a cognitive decline, memory trouble, ongoing or early dementia, then we're going to be very skeptical.
You would not be a good candidate.
Right, generally speaking.
So with the deep brain stimulation, the main goal is to control the rigidity or the tremors or both?
Well, the three things that help the most with deep brain stimulation, one, tremor certainly is affected far more than any other symptoms of Parkinson's disease. Rigidity, certainly we see right away after implanting the DBS electrodes. And then slowness also. Those are the three things that we typically expect to improve. as far as gait and balance, it's a very kind of a questionable area. And actually, much of the data talks about them being worsened after deep brain stimulation. So
one
that's
of the
why we're
side
becoming,
effects.
absolutely, that's why we're becoming very careful in our selection process. The other thing I want to make a note about, which I've come to realize that people also misunderstand, that deep brain stimulation is a therapy for other Parkinsonian syndromes, like atypical, as you mentioned in the beginning. Well, I wanted to clarify that it's only approved for idiopathic Parkinson disease. With everything else, actually it worsens things to the best of our knowledge. So people have to be very certain about their diagnosis, what are they getting into, and do they have the right team in place to get this therapy working as they need to.
So it's very sophisticated.
Absolutely.
And show us the electrode and what a fine
Right.
little
Well, it's a
wire
really,
that is.
I know, and it
goes-
is very fine, and we'll do our best.
I'm sure the camera can pick it up.
Right, so this is one of the DBS electrodes. We don't have the complete, package how we install it, but I just wanted to give you a sense of that these are the 4 contacts. You see these metal contacts here?
Down at the
0,
bottom.
1, 2, 3, 4 of them that are actually should call the brains behind working it. And through these contacts is how we stimulate the particular areas of the brain where actually we think the disease is happening. So how I explain to patients DBS is that your brain is all kind of misfiring, because brain is nothing
Like
other
a
than
circuit, didn't you say?
Absolutely. It's a circuit with a lot of wiring connections, one nuclei talking to the other, cells talking to each other, and now you have a disease where they just don't know what to tell each other. So your leg isn't moving, your arm is shaking, you're slower, stiffer. And what we do with this, which is as brilliant as it sounds, but this DBS electrode through stimulation overrides it and overrides the abnormal signal and delivers a signal which is more regular, more rhythmic, even though it's not the normal signal.
So this end goes into the brain.
Absolutely, into that target nuclei, which may be, there are 3 different targets, potentially speaking, we use, there are others, but one of the potential targets, and it will sit there, and through the DBS programmer, we will stimulate.
And then so the other end goes
Absolutely.
into a
Absolutely.
little...
Through wires being connected out of the skull, under the skin, it goes to a little battery pouch, an impulse generator, which actually sends the impulses to this electrode. And we work through this programmer to set up those settings here. So yes, it is fascinating what you can do.
I just got a time cue that we have 4 minutes left only. So I want to quickly shift. Those who benefit from this, wonderful, but as you say, probably the majority do not. So medication is the next thing I want to talk a bit about. And as you said before, levodopa has been the main drug, but there are others. The drugs, though, have tough side effects too, don't they?
Right.
I mean, you're not home free.
True, absolutely. And with levodopa, even though it is still the one, I use this terminology because I heard it from someone who's a good friend of mine. But the problem is the side effects and the complications long term. But we have now many other drugs which either augment or take care of these problems which come along with Cinemet. So the options are beyond levodopa now. And each stage of the disease and each age group will determine what kind of drug they'll benefit from the most. But there are many that we use now, more than levodopa.
And that's exciting to know that there are other things out there on the front. We have some websites that we want to give the audience so you can pursue learning more about Parkinson's by going to these websites. The first one is the Capistrant Center, where Dr. Bajwa is the medical director. That website is www.bethesdahospital.org/Capistrant_center. You can learn a lot more via that. And then we have 2 other websites. The first one is the APDA Association of Minnesota, www.apdaparkinson.org. The number is 1-800-302-7762. And then the National Association, we have a website for them too. It's not a typo, it's the same website, a different phone number, however. And that number is 800-223-2732. Well, do we have another minute or two left? I want to just ask you a couple more things in terms of managing exercise, diet. Those are things people can also do.
Absolutely.
And exercise is a biggie, isn't it?
Absolutely. We have learned just in the last decade or so, more than we did, that aerobic exercise does pronouncedly affect your symptomatic control to Parkinson's disease. So there's absolutely that old wisdom that a good exercise, good diet, healthy lifestyle is not only good for your heart or your diabetes, it's actually good for your brain too. So that's how people can help themselves by helping their Parkinson's disease.
Is it possible to slow the progression via exercise?
That's a very interesting question, which has been raised about every potential therapy that has ever been around Parkinson's disease. But the short answer is we don't know yet.
Lots of things we don't know, aren't
absolutely.
there? And another one, and you and I don't have time to talk about this now, but we talked about it some on the phone, healthcare reform and how that might change the treatment and whole world of Parkinson. But that's another show. I might have you back to discuss
Absolutely
that.
sure, yes.
Thank you so much,
Oh, you're
Dr.
welcome.
Bajwa, for being with me. We've learned so much, and I'm so pleased you're in Minnesota.
Well, thank you so much.
Adding your expertise to our healthcare here. Thank you for being with us. We'll be back again next week. Until then, have a good week.